Good morning, everybody. This lecture will be on hypertension. I will try to make it in two parts. It is mainly for fourth-year students, but anyhow, I gave some details so that the sixth-year students can benefit from it. Of course, this hypertension is changing knowledge. That's why I gave the date. We are in March 2020. We'll go through physiology, definition, pathogenesis and etiology, clinical manifestations, complications, investigations, and management. Before everything, I would like to ask why we treat hypertension. What's our objective? Think of a while. It is not a matter of decreasing blood pressure as a figure. The idea is to reduce the incidence of adverse cardiovascular events like coronary artery disease and cerebral artery disease, stroke, and cardiac disease. This is the main objective in treating hypertension. Now, we'll go through some physiology. This is the normal circulation. You have blood in the left side, the oxygenated blood pushed by the left ventricle to the aorta and major arteries, and then to the small arteries and arterioles for oxygenation, and then it is received by the venous circulation to the right ventricle, and the right ventricle pushes blood to the lung. The left side pressure is called systemic hypertension, systemic blood pressure, and any rise in this pressure is called systemic arterial hypertension or systemic hypertension. The right side pressure from the right ventricle to the pulmonary artery is called pulmonary pressure, and when it increases it calls pulmonary hypertension. The left ventricle generates the systemic pressure. The contraction of the left ventricle pushes the blood to the circulation. So there are three elements that make this blood reach the tissue. The blood has to reach the tissue under certain pressure. This pressure is generated by contractility of the left ventricle, by the amount of the blood, and by diameter of the blood vessels. Remember these three elements when we talk about treatment of hypertension as well. So blood pressure is the force of blood against the artery wall as it circulates through blood. The left ventricle generates a pressure. This pressure against the wall is the arterial pressure. The pressure in the aorta will be high, something around 120 systolic over 80 diastolic. In the arteries to be lower, peripheral arteries and capillaries lowest, and then the venous side. But remember, these arteries, when subject to high continuous pressure, they will suffer in some way. This is one of the pathologies of hypertension. If you subject this artery to a high pressure, then the wall will suffer and the ventricle has to contract in a forceful manner. Now, what regulates the blood pressure? Normally, the blood pressure, whether hypo or hyper, is regulated in a matter of seconds by the nervous system, in a matter of hours by fluid shift, in a matter of days by the kidney. I will give an example of the immediate regulation of blood pressure by baro and chemoreceptors. In the aortic arch, you have a receptor, and in the carotid, these are receptors that sense the blood. If, for example, you have hypotension, loss of fluid for any reason, severe diarrhea, blood loss, whatever, these will sense the pressure in the wall and send impulses to the central nervous system, and the central nervous system through the sympathetic nervous system will give impulses to the heart will contract, there will be tachycardia, more contraction, and vasoconstriction. This is the response to high blood pressure, to low blood pressure. On the contrary, when you have a high blood pressure, then the impulses will be the opposite. You will have bradycardia and vasodilatation. Of course, this needs a normal autonomic nervous system. So if you have a patient with autonomic neuropathy like diabetes, you can have a surge of blood pressure or you can have postural hypotension. Now about the level of blood pressure. Actually, the level of blood pressure is related to the cardiovascular risk, whether these two terms are different, by the way. Cardiovascular is not coronary artery. Is related to the cardiovascular risk, that's stroke and CVA. But we don't have a specific cut-off so that we can say this level is serious, unless we join that cut-off with certain risk factors. So the blood pressure is linked to the age of the patient. The older the patient, the more the risk. The gender, male patients, overweight patients, those who don't have physical activity, or those who are smoking, having high cholesterol, diabetes, and remember, these are the risks of atherosclerosis. So anyone or multiple of these risks with any level of blood pressure will put the patient on the risk of cardiovascular disease. Obviously, a patient without this, he will be risky, but not that risk. So we don't have a certain cut-off level to say this patient is hypertension or not. So to define hypertension, although there is some sort of agreement that mild hypertension is when systole more than 140 and diastole 90, but to define hypertension, it is the level of blood pressure, systole and diastole, at which the risk of complications and benefit of treatment outweigh the cost and side effect. That's to say, if you have a patient with hypertension and smoking, then he will benefit from treatment, okay? And he have a risk of cardiovascular disease. So here I should give treatment regardless the cost or side effect. I will consider that, but I should give treatment. On the contrary, if I have a patient without a risk factor, say a female patient with blood pressure 150 without risk, then I will subject this patient to side effect and probably cost of drug. I should consider whether to give treatment or not. So the classification of hypertension is three groups. We have a category, and we have systolic and diastolic blood pressure. The optimal blood pressure is 120, less than 120 over 80. It's very difficult, actually. And you have a normal blood pressure, less than 130 over 85. And you have a high normal, 130, 139 to 85 to 89, previously called pre-hypertension. Hypertension have three grades. Grade 1 or mild, 140 to 159, diastole 90, 99. Grade 2 or moderate, 160, 170, 100 to 110. Grade 3 or severe, more than 180, more than 110. This is regarding the grades of hypertension. There is another entity of hypertension, especially in the elderly, called isolated systolic hypertension. Elderly people do not have rise in diastolic blood pressure because of loss of elasticity and recoil of the artery. The diastole is less than 190, but the systole is rising. This is called isolated systolic hypertension. Grade 1 is 140 to 159, and grade 2 more than 180. So in summary, you have a normal or optimal blood pressure. You have hypertension of three grades, 1, 2, 3, or mild, moderate, and severe, and you have isolated systolic hypertension. Now, what is the pathogenesis of hypertension? Because we don't have a clear cause of hypertension. Actually, there are certain organs that play a role in the blood pressure. The kidney, regarding the blood volume, renin-angiotensin system, etc. The heart, regarding cardiac output and contractility. The blood vessel, vascular tone, endothelial function, etc. And the brain, the nervous system. So there are factors: renal function, peripheral resistance, vascular tone, endothelial, etc. If you have disturbed renal function, you might have, this will contribute to regulation and development of hypertension. If you have increased peripheral resistance, if you have disturbed high vascular tone, if you have endothelial dysfunction or autonomic dysfunction, these all play a role in regulation and development of hypertension. But regarding the cause of hypertension, the patient will ask you why I developed hypertension. Actually, the answer is a bit difficult. In 95% of the patients, we don't have a clear cause for hypertension. That's why it's called essential hypertension. Genetic factors do play a role in 50% of the cases, and environmental factors play a role, like high salt intake, heavy alcohol consumption, obesity, lack of exercise, and the so-called impaired intrauterine growth. So you have a combination of genetic and environmental factors that play a role in development of hypertension. But in 5% of population, you might find a secondary cause of hypertension. 5%. When you have a renal disease, when you have endocrine disease, when you have drugs and sometimes alcohol, obesity, and pregnancy. And this is a detailed table. I will not go to the detail. You can look later. And alcohol intake, obesity, and pregnancy, preeclampsia or eclampsia. And when you have a renal disease, polycystic kidney or glomerulonephritis, these are causes of secondary hypertension. Pheochromocytoma and Cushing, these are endocrine causes of hypertension, and some drugs like especially oral contraceptive and long use of steroid, these can cause, and carbinoxolone and some sympathomimetic agents, these can cause hypertension. And lastly, coarctation of the aorta. So 95% of the cases you don't have a clear cause of hypertension. In only 5% of the cases you might find a cause like renal disease, endocrine, drug, and coarctation. Now, what are the clinical features of hypertension? What are the signs and symptoms and complications? We'll talk about complications also. Regarding symptoms, it is strange to tell you that hypertension is asymptomatic. You don't have any symptom. And until diagnosis is made, it's only you don't have any symptom. But on routine examination or when you have a complication. And that's why it's advisable to detect occult hypertension, to check blood pressure in every patient above 40 each 5 years, although people will not believe in this. Now you immediately ask, what about headache? Actually, most of the references, do not agree that hypertension causes headache, except one condition, and that's hypertensive encephalopathy. This is hypertension with stage 4 retinopathy, papilledema. Hypertension will cause headache and neurological symptom. Otherwise, actually headache is a cause of hypertension and not hypertension is a cause of headache. For example, a patient with migraine, the pain and stress of the patient will cause some release of sympathomimetic catecholamines. And at the time of headache, the patient will have high blood pressure and wrongly will be diagnosed as hypertension. So it is better not to check blood pressure in somebody having headache or pain elsewhere. When the headache, try to give him an analgesic, sedative, whatever. When the headache is over, then check his blood pressure, because you will have falsely high blood pressure. And so many patients with atypical headache for another reason has been diagnosed as hypertension, and you might hear loose or do not detect very serious cause of headache, for example, raised intracranial pressure or brain tumor. Be careful to label headache due to hypertension. Now, what are the signs of hypertension? Actually, the signs are due to, if there is underlying cause, a clue to the cause or to associated risk, or to complication, which I talk about in a minute. Underlying cause, you might have coarctation of the aorta, then you have radiofemoral delay, polycystic kidney, then you have enlarged kidney on palpation, and renal artery stenosis, you might hear a bruit, or the characteristic facies and habitus of Cushing syndrome. Then risk factors like hyperlipidemia, carcinosis, etc., or the signs of complications in the heart, left ventricular hypertrophy, loud second heart sound, atrial fibrillation, heart failure, etc., and in the eyes or optic fundi, you might have accident hemorrhage, and CNS stroke, and the arteries, evidence of atheroma, and the kidneys. I'll come to these complications. Now, what are the complications of hypertension, or the adverse effect of hypertension, or the so-called target organ damage in hypertension? Actually, these are the main targets: the heart, the brain, and the vasculature. For simplicity, I will tell you that the effect of hypertension may be direct and indirect. Direct damage of the vasculature due to high blood pressure. The arteries are subject to high blood pressure, so they are directly damaged. But most of the complications of hypertension actually are due to indirect damage through another disease called atherosclerosis. And you know well this disease. The complications of hypertension are mostly due to atherosclerosis, for which hypertension is one factor. Atherosclerosis of the coronaries, atherosclerosis of the cerebral arteries, atherosclerosis of the limb arteries. Atherosclerosis of the coronaries will cause and can cause angina and myocardial infarction in the brain, cerebral infarction and transient ischemic attack, and the kidney microalbuminuria and renal failure, and the blood vessel damage I will talk about. Regarding the blood vessels, you have large and small arteries. If you subject these arteries to high pressure continuously, by the way, hypertension by definition, and I will tell you during checking of blood pressure, is a chronic process. When these arteries are subject to chronic pressure, they will get changes in their walls. Their walls are composed of intima, media, and adventitia. If you subject this to a high pressure, then the large arteries, internal elastic lamina will thicken, the smooth muscle in the media will hypertrophy, and the fibrous tissue will be deposited. So this artery will be dilated and tortuous and stiff, less compliant. And dilatation, sometimes you might find dilated aorta in the chest x-ray, unfolding of the aorta. The small arteries, those diameter are less than 1 millimeter, then they get arteriosclerosis in their walls. The lumen become narrower and even microaneurysm. This narrowing of the lumen will cause increased peripheral resistance and will perpetuate hypertension. Of course, the arteries might have atheroma, but remember the structural changes in the vasculature. Narrowing will perpetuate and aggravate hypertension, increasing the peripheral vascular resistance and reducing renal function. And sometimes the large arteries get aneurysm and aortic dissection. So the small arteries get dilated and stiff, the large arteries, and the small arteries get narrowed and even microaneurysm. This is the first target. The second target to be affected is the retina or the eye. Actually, the retinal arteries are mirror image to the severity of hypertension. The severity of hypertension is reflected by arterial damage in the retina. It will reflect arterial damage elsewhere. That's to say, if you have arterial damage in the retina, then you have microarterial damage in the kidney, then the glomerular arteries has been damaged. You should look for example, if you have retinal lesion, to microalbuminuria. The type of the lesions are cotton wool exudate, and which indicate renal ischemia or infarction, which fade, and hard exudate and microaneurysm like that of diabetes and central vein thrombosis. But anyway, there is grading of retinopathy. First, second, and third, and fourth. The first grade is arterial thickening. There will be arteries that are thick and tortuous, and they have increased reflex, light reflex. The second grade, this will nip when they cross the vein. And third, they will have ischemia, hemorrhage and exudate, and fourth, papilledema, and these are the figures. This is stage 1, that's refractiness is increased because of increased thickening. Then the artery, when crosses the vein, there will be nipping. And third, you will have exudate. And fourth, you have exudate and hemorrhage and papilledema. Papilledema with exudate and hemorrhage, when associated with high blood pressure and headache or neurological symptoms and signs, this is called hypertensive encephalopathy. Anyway, presence of papilledema indicates a severe degree of hypertension. There is another complication called central vein thrombosis. The third target is the central nervous system. Of course, you know the brain has arterial supply, carotid, and then the anterior, middle, and cerebral arteries. You can have a stroke or CVA, cerebrovascular, by occlusion of one of these arteries by atherosclerosis, like myocardial infarction. And again, you might have transient occlusion and carotid atheroma. This is called transient ischemic attack, somewhat like angina in the heart and infarction. The third is subarachnoid hemorrhage. And the fourth, as I mentioned, hypertensive encephalopathy, papilledema, high blood pressure, neurologic symptoms, plus papilledema. Of course, the CT scan in papilledema, in hypertensive encephalopathy, will show hemorrhage around the basal ganglia, and it is irreversible, even the neurological deficit, when you treat it. And you can see the brain image CT scan, the infarcted area and the hemorrhagic area. It's an infarct and there's a hemorrhage in the brain. The fourth target is the heart. The heart is suffering in two ways. It has the coronaries, which are the medium-sized arteries subject to atherosclerosis, and it has the left ventricle that contracts against the high pressure. So there will be higher incidence of coronary artery disease like angina and myocardial infarction, atherosclerosis of this. Angina and myocardial infarction. But what happens to the ventricle? The high blood pressure in the arteries, the ventricle has to contract against the high pressure. So the ventricle will hypertrophy. Left ventricular hypertrophy will double the risk of mortality and morbidity in hypertension. This is number one. So any patient with hypertension and left ventricular hypertrophy, whether clinical, radio, by echo, then he has a double incidence of mortality and morbidity. This hypertrophied ventricle you can detect actually by forceful apex and by loud component of second heart sound and by a fourth heart sound. Fourth heart sound is due to atrial contraction against a stiff ventricle. This ventricle will be stiff. When the atria contract, it will produce a fourth heart sound, and the aortic component closure will be high. You have second heart sound. Unfortunately, it is not written here. A hypertrophied ventricle will have a diastolic dysfunction. It's a postgraduate entity anyway. Then it will have systolic failure. So, left ventricular hypertrophy, diastolic dysfunction with atrial contraction against a stiff ventricle, and then heart failure, left ventricular failure. I repeat this confusing point. Severe hypertension will cause left ventricular failure through hypertrophy and then diastolic dysfunction. The atria which contracts against a stiff ventricle will get atrial fibrillation. So imagine these complications of hypertension. You have left ventricular hypertrophy, and by echo we can detect diastolic dysfunction, and then later hypertrophy by echo and by ECG. This hypertrophied ventricle will end in left ventricular failure. The atria indirectly will be subjected to it will contract against stiff ventricle. It will have atrial fibrillation and produce fourth heart sound before the atrial fibrillation. So in summary, the heart and coronaries will suffer from hypertension. The coronaries, angina and myocardial infarction. The left ventricular hypertrophy and left ventricular failure with higher incidence of atrial fibrillation. That's why hypertensive patient has higher incidence of atrial fibrillation. The last organ is kidneys. The kidney has again large arteries and small arteries. The large arteries affected by atherosclerosis, the small arteries by direct affection. So long-standing hypertension will damage the renal vasculature and produce albuminuria, micro and then microalbuminuria, and then will end in renal failure. How this damage occurs? What are the types? Atherosclerotic vascular regions with large arteries. This will lead, this is called preglomerular arteries and arterioles, will lead to ischemia. Of course, remember, ischemia will produce renin-angiotensin and increase the blood pressure, and the situation will be complex when you have renal failure or renal damage in hypertensive patient. Again, direct damage of the small glomerular capillaries. This will end in glomerular hyperperfusion and loss of autoregulation and glomerular sclerosis and tubular necrosis and renal failure. The issue will be complicated when you have renal failure because it will perpetuate the hypertension. I will summarize the complication and you'll take a rest now and then go to the second part of the lecture. To summarize the complications of hypertension, we are afraid from complications of hypertension which are direct and indirect. the direct vascular damage, the indirect through atherosclerosis. The large arteries will get stiff and tortuous. The small arteries will get narrower and get microaneurysm. The retina will have 4 grades of damage to the arteries. The last is papilledema, which is part of hypertensive encephalopathy. And the third organ to be affected, central nervous system, in the form of a stroke or CVA or transient ischemic attack or subarachnoid hemorrhage or hypertensive encephalopathy. The other organ to be affected is the heart, again angina and myocardial infarction, coronary artery disease, or left ventricular hypertrophy, diastolic dysfunction of the left ventricle, and then left ventricular failure. And lastly, the kidney in the form of both micro and microvascular damage, starting as microalbuminuria and then microalbuminuria. Hope this lecture was fruitful. Have a rest, and then I will upload later the next part of the lecture. See you again, and thank you very much.